Welcome back, coders, billers, and auditors. You're tuning right into Part 10 of our Shoulder Arthroscopy and CPT Coding Mastery Series. If you've been with us for the first 9 parts, well, you already know we're completely tearing down the complexities of orthopedic coding. Today, we're targeting 2 incredibly common, yet, frequently misunderstood arthroscopic procedures. We're looking at the Mumford procedure and the surgical management of frozen shoulder. So get your CPT books ready, grab those highlighters, and let's just get to work.
But before we tackle today's new codes, let's do a rapid-fire recap of Part 9, just to get our coding brains totally re-engaged. Last time, we broke down the intense battle between CPT 2982 for limited debridement and 2983 for extensive debridement. Remember our golden rule? It all comes down to discrete structure counts and the anatomical zones addressed. If the surgeon's just doing a localized cleanup, it's 2982. But if they're extensively debriding multiple discrete structures in completely different anatomical areas, you hit that 2983. All right, today we're setting a new mission, mastering acromioclavicular, or AC, joint pathology and adhesive capsulitis.
Here's our roadmap for today's explainer. We're looking at the Mumford procedure, Lysis of adhesions, adhesiolysis versus routine debridement, an interactive coding scenario, and then wrapping up with our key takeaways.
Okay, let's dive right into Section 1, our deep dive on the Mumford procedure, CPT 29824. Let's establish our authoritative baseline by looking directly at the official CPT descriptor for 29824. It reads, arthroscopy, shoulder, surgical, distal claviculectomy, including distal articular surface. This is commonly referred to in operative reports as the Mumford procedure. Now, the absolutely most critical phrase in this entire descriptor is including distal articular surface. I mean it. If the surgeon only shaves off a tiny little bone spur but doesn't actually resect the articular surface of the distal clavicle, you cannot code 29824. Accuracy here is everything.
So, you might be wondering, why does a patient even need this procedure? Well, look closely at the AC joint. That's where the collarbone meets the shoulder blade. In a totally healthy joint, there's a nice smooth gliding motion. But in these specific patients, we're seeing severe acromioclavicular joint osteoarthritis. We see angry, inflamed tissue and painful hypertrophic osteophytes, which are, essentially just large bone spurs. And these spurs cause severe impingement right at the distal end of the collarbone. Every single time the patient lifts their arm, it's just bone grinding on bone. This post-traumatic or degenerative wear and tear is absolutely excruciating. So here's how that translates into the surgical intervention. The surgeon starts with a standard scope insertion for direct visualization of that damaged AC joint. Then, picture a high-speed arthroscopic burr seamlessly shaving away the distal terminal portion of the collarbone. The surgeon is physically removing that arthritic distal articular surface to widen the joint space and relieve that awful mechanical compression. Once that bone is gone, that painful friction is literally eliminated.
All right, shifting gears to Section 2, Lysis of adhesions, CPT 29825, and restoring glenohumeral mobility. Here is our CPT code 29825, arthroscopy, shoulder, surgical, with lysis and resection of adhesions with or without manipulation. Seriously, I want you to highlight, underline, and circle that phrase, with or without manipulation. This is a massive compliance detail. When you're reading an operative report, surgeons will frequently document that they manually manipulated the shoulder under anesthesia just to break up scar tissue. As coders, we have to recognize that this manual manipulation is inherently built right into the 29825 code descriptor.
The sheer severity of this pathology is kinda staggering. We're talking about adhesive capsulitis, universally known as frozen shoulder. See, a normal shoulder capsule is like a thin, flexible, balloon-like membrane. But a frozen shoulder features severe fibrotic thickening and just aggressive inflammation. The capsule literally shrinks down and glues itself around the humerus, leading to joint contracture and a profound, agonizing loss of both passive and active range of motion. The patient simply cannot move their arm at all.
To fix this, the surgeon introduces arthroscopic cutting instruments, very often a specialized radiofrequency wand. Imagine this glowing wand effectively slicing and just melting through thick, inflamed intra-articular adhesions. The surgeon meticulously lyses, meaning destroys, and divides these dense fibrotic capsular bands all the way around the joint. By circumferentially releasing this incredibly tight tissue, they can instantly restore the full, free movement of the glenohumeral joint.
Moving on to Section 3, adhesiolysis versus routine debridement, and how to navigate these complex NCCI edits.
Okay, Keep this NCCI exception in your back pocket. According to NCCI edit guidelines, there are definitely exceptions to the bundling rules for debridement. Specifically, extensive debridement, that's code 29823, performed in a completely different discrete anatomical area of that exact same shoulder, while that can be reported separately alongside the Mumford procedure, 29824. Documentation is king here, folks. The operative report has to clearly distinguish the separate anatomical areas being treated if you want to bypass the edit.
And this brilliantly illustrates the real difference between true adhesiolysis and just, routine debridement. A lot of coders see the word adhesions and they immediately jump straight to 29825. But look closely. CPT 29825 requires a true circumferential capsular release specifically targeted at treating a frozen shoulder contracture. On the flip side, CPT 29822 or 29823 is used for localized soft tissue shaving, like maybe cleaning up some frayed labral tissue or mild synovitis. If the surgeon just snips a tiny little band of scar tissue just to see better, that is routine debridement. It's definitely not a full lysis of adhesions.
So the absolutely crucial point is this. Manipulation of the shoulder joint under anesthesia, or MUA, is strictly and explicitly included in code 29825. Do not let a separate paragraph in the operative report detailing a 5-minute manipulation trick you into billing a separate MUA code. Unbundling this is a direct compliance risk, and I promise you, it will trigger an audit faster than you can blink. Let's put this to the test in Section 4 with an interactive coding scenario. Time to apply your knowledge. Okay, here's your patient. A 54-year-old presenting with severe right adhesive capsulitis and painful AC joint arthritis. The orthopedic surgeon performs an arthroscopic lysis and resection of dense anterior and inferior glenohumeral adhesions, coupled with manual shoulder manipulation to regain full range of motion. Through an anterosuperior portal, the surgeon also performs an arthroscopic distal claviculectomy, removing 8 millimeters of the distal clavicular articular surface. I want you to read that carefully. Formulate your CPT codes. Go ahead, I'll give you a second to think about it.
All right, let's break down the solution line by line together. First, you should have reported CPT 29824 with an RT modifier for the right shoulder. This perfectly captures the Mumford distal claviculectomy, and it's totally supported by the documentation stating that 8 millimeters of the articular surface was removed. Next up, you report CPT 29825, a pending modifier 51 for a multiple procedure, and that RT modifier again. This captures the extensive arthroscopic lysis of adhesions for the adhesive capsulitis. And the absolute key rationale here, the manual shoulder manipulation is inherently included in 29825. We do not code it separately. If you nailed that, you are honestly coding at an elite level.
And finally, Section 5, our key takeaways and episode wrap-up.
Here are the core concepts that need to be permanently etched into your coding brain today. Number 1, 29824 absolutely requires the resection of the distal articular surface, the Mumford procedure. Number 2, 29825 isn't for mild scar tissue. It targets severe fibrotic contracture and clinical frozen shoulder. Number 3, manipulation is definitively bundled into 29825. Never, ever bill it separately. And finally, always remember your NCCI exceptions. Extensive debridement, 29823, performed in a completely separate area, can totally be coded alongside 29824.
And that brings Part 10 to a close. As you head back to your charts today, I really want you to ask yourself, are your practice's revenues bleeding out because of a misunderstood NCCI edit, or are you actually catching these subtle bundling traps before they ever even hit the payer's desk? Next time, in Part 11, we're tackling subacromial decompression and the notorious add-on code rules for plus 29826. Keep your eyes sharp, keep learning, and as always, decode healthcare with Harshal.